Thank you so much. I'm so excited to share our work today on investigating the kinetics of vaccine-elicited antibody responses in our cohort of infants from Botswana. So to start, I'm just going to go through some background information, and then I'll walk you through the assays we did. So we conducted pneumococcal ELISAs, pediatric vaccine multiplex assays, and then I'll round out with our conclusions and future directions. So in sub-Saharan Africa, preventative programs of maternal to child transmission of HIV have significantly reduced the number of infants born with HIV. However, 30% of all children born in some areas remain HIV exposed but uninfected. And in this cohort of infants, they have a higher mortality rate than those infants who are born to mothers who are not infected with HIV. And that mortality can be related to a higher susceptibility of lower respiratory infections, which is often caused by Streptococcus pneumoniae. So for our cohort, these samples were received from a referral hospital in 3 clinics in Gaborone, Botswana. In Botswana, there are high incidence of respiratory infections, particularly pneumonia. And factors that can contribute to this include the maternal HIV status, child undernutrition, and use of solid fuels in homes, which can lead to respiratory infections. So despite the high incidence of respiratory infections in Botswana, they do have a very robust national immunization schedule. This table here is provided by the World Health Organization. It includes a list of vaccines that infants receive in their first year of life. In this study, we'll be looking at hepatitis B, diphtheria and tetanus and pertussis and Haemophilus influenza, and then the pneumococcal conjugate vaccine and measles and rubella vaccine. So for our cohort, we received 300 mother-infant pairs who enrolled in this study, and they came to the hospital monthly in the first year of their infant's lives. And we received samples from 0, so at birth, 5 months, and 12 months. And so far, we've tested 74 infant samples, 22 of which were exposed to HIV but uninfected, and 52 who were born to mothers who did not have HIV, so they were not exposed and not infected. And our goal here is to determine the effect of the HIV exposure status on the immunogenicity of a pediatric vaccine panel in this cohort. So the first question we asked was if these HIV-exposed uninfected infants develop vaccine-elicited antibodies to the serotypes included in the pneumococcal conjugate vaccine. And so we investigated this by conducting pneumococcal ELISA assays, and we tested the antibody binding to the 13 serotypes which are included in this vaccine, which are listed here. So we found that antibody levels increased from birth to 5 months, but decreased at 12 months. And so just to orient you here, the x-axis includes our 3 time points, so birth, 5 months, and 12 months, and then our y-axis is the log concentration of the antibody binding. And so for the PCV13, that pneumococcal conjugate vaccine, the infants received it at 2 months, 3 months, and 4 months. So the 5-month boost that we see is following vaccination. And we found this increased binding for all of the serotypes that we tested. So next we wanted to look at the difference between HIV exposure status between exposed infants and unexposed infants. And we found that for the serotype 6A, 18C, and 23F, the HIV unexposed, uninfected infants did have a significantly increased antibody response at birth. And again, so HEU and HU are our 2 exposure groups on the x-axis, and then our y-axis shows the concentration. And we tested this by Mann-Whitney-U, and we only found that significant difference in the groups among those 3 serotypes. For the other serotypes, there were no differences between groups and among the different time points. So next we looked at the vaccine-elicited antibody responses to a common vaccine antigens that infants received between our 2 groups. And so we tested this by pediatric vaccine multiplex assay, which is basically a BAMA assay where we tag beads with their antigens. And so we looked at Haemophilus influenzae type B, pertussis toxin, hepatitis B surface antigen, tetanus toxoid, RSV, respiratory syncytial virus, rubella, and diphtheria. And so we found again an increase from birth to 5 months and a decrease at 12 months. Here we see pertussis diphtheria and HIB, Haemophilus influenzae, and infants received these vaccines at 2, 3, and 4 months. So we saw that increased antibody response following vaccination at 5 months. Something to note here, so the WHO has protective cutoffs for antibody levels in infants, and that is this dashed line here. So infants following vaccination had protective antibody levels, and we can see that for diphtheria, for all 3 of these antigens, the antibody levels declined at 1 year, so following vaccination. So next, we looked at more antigens in this panel. Hepatitis B is an interesting one. We saw no difference among the time points tested. To note though, infants were vaccinated at birth, so the antibody levels were maintained throughout the first year of life. And for tetanus, we saw that infants were born with high maternally derived antibodies, but even following vaccination at 2, 3, and 4 months, infants did not have a significant antibody boost higher than that of the maternal levels. And those antibody levels continued to decrease throughout the first year of life. For rubella, infants received their vaccine at 9 months. So we did see a boost following vaccination here at 12 months. However, in the first few months of life, so we did see that decline in the antibody levels from birth to 5 months. And for RSV, infants did not receive a vaccine, but we did see that infants were born with high maternally derived antibodies, which declined throughout the first year of life. And something that's important to note here too is that we have this cohort of infants that have high antibody levels comparable to that of the maternally derived levels, which is indicative of a group that had clinical infection. So there we go. For this group, we also looked at the difference in exposure statuses between the 2 groups, and we only found a significant difference in HIV exposure status for tetanus toxoid. And here we see that HEU, so HIV unexposed, uninfected infants, had a significantly higher antibody level at birth compared to HIV exposed infants. And we determined this by Mann-Whitney U test. And this was the only antigen tested in which we did see a difference. For all others, the HIV exposure status did not indicate any different levels in antibodies. So next, we calculated the frequency of infants who had antibody levels above the WHO protective cutoff between our 2 groups. So you can see here in this table the cutoff for protective antibody levels for these common vaccines. Something to note is that we also looked at RSV and pertussis, and those do not have recommended protective cutoffs. So we don't have that data here. But we didn't see a difference in the frequency of infants with protective cutoffs above that WHO recommendation between our 2 groups. Except for looking at HIB and diphtheria, we did see a significant increase in the frequency of infants with protective antibody levels following vaccination. So both of those vaccines were administered at 2, 3, and 4 months, which is where we see this increase. And in particular with diphtheria, we see that we had no infants who were HIV exposed uninfected who had antibody levels above the protective cutoff. And then following vaccination, we had almost 100% who did. All right, so in summary, infants from Botswana develop robust antibody responses following vaccination, but as we saw, these antibodies do decrease during infancy, so up to their first year of life. And then we also saw that maternally derived antibody levels against several of the antigens, so those 3 pneumococcal serotypes and tetanus, were significantly higher in the HIV unexposed, uninfected infants at birth. And we did see that those did decline throughout the first year of life as well. And then frequency of infants with antibody levels above the WHO cutoff does not differ between our 2 exposure groups following vaccination. And so our implication here is that the HIV exposure status does not impact the antibody response to these respiratory virus vaccinations in infants. And so something that we want to look at going forwards is that we tested the magnitude of responses here, but we want to understand the functionality. The magnitude, the levels might not matter, but we want to look at the FC receptor binding between these two groups to see if that has any difference, and then also look at antigen-specific IgG subclass response. Then something also that's important to note here is that we've only tested 74 samples and we have a 300 sample cohort. So I will also be doing more assays for ELISA and PVMA in 76 infants. So we'll have a larger sample size and see how that impacts our findings. So I would just like to thank my mentor, Dr. Fuda, for all of her help on this project, and Dr. Matt Kelly, and these are his samples that he receives, and his team, especially Rebecca Young, who's his statistician, who helped me run some stats for this. And I'd also like to thank Grace Lee. She's a previous lab member who spearheaded this project, and I took it over from her, and all members of the Permar Fuda Lab for their help in helping me put together this presentation. And thank you to Duke CFAR for funding and NIH. And now I can take any questions.
Great, thank you so much, Emily. Fantastic presentation. So we will now open this abstract for discussion. And I do have a question that came in via chat from Dr. Ferrari. The question is, given the differences of antibody levels that you saw at birth between the exposed uninfected and the unexposed uninfected, the question is, was there a difference, or do you have any idea what the differences of antibody levels were in those mothers? So is that a reflection of the differences in antibody levels in those mothers? Do we know whether that's what's driving this versus the kind of exposed in utero state?
Yeah, that's a really great question. I do not have that information about the antibody levels in the mothers. I could follow up with Matt to see if they received that data at enrollment period, but I'm not sure.
Great. And then one other follow-up question is, so given those differences, right, in antibody levels at birth, do we know if that translates prior to kind of getting that boost from the actual vaccination schedules to an increase in disease? Do these children have higher rates in early, in those first 6 months of life with these types of upper respiratory infections or other infections?
Yes, I believe so, especially with pneumococcal diseases. And then like we saw too with RSV, I think these infants do have higher rates, higher incidences, especially in that region in Botswana.
Great. And one more question has come in. So do you have any information on the impact of HIV exposure in utero and the relationship on the mucosal antibody response? So do we know whether or not that is, in fact, something that we would expect to see from prior data?
Yeah, I believe that Dr. Matt Kelly's lab has done some work on that. Part of the study is also looking at the microbiome and the impact on HIV exposure status with that. So that's some work that they have done. I'm not sure what their findings are with that, but I believe they do have that information. Yeah.
Great. Thank you so much, Emily. Great job. Really great work.